Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Matt. How are you doing this morning, Matt?
I'm doing well, thank you.
Since this is the first time you're on the podcast, would you please do just a quick introduction?
Sure. I am a pediatric intensivist. I've been in the military now over 20 years, worked as a pediatric intensivist for the past 10 years or so. Currently chief of the PICU at Brooke Army Medical Center. But definitely have a specific interest in pediatric trauma and resuscitation, which I believe is why you got me on the show.
Yep, that's absolutely correct, because today we're going over everybody's nightmare, pediatric patients. I can remember, several deployments where, some deployments you would hardly ever see hardly any children, as far as, seeing them medically anyway. Versus other deployments, like half the patients that you saw were pediatrics. So I know as soon as somebody mentions, "Hey, I have a pediatric patient coming in," generally everybody gets very apprehensive. Why is it we have such a hard time dealing with pediatric patients?
Well, I think that fear comes because, one is it's probably just because of lack of experience working with kids. So I feel like, I think the sense that some people have if they haven't worked with children a lot is that they need to do everything different, or they don't know what needs to be done. Where the reality is that, you can really just stick to your ABCs, and, with a few caveats, which, we'll go over some of those differences today. Taking a deep breath and, approach things systematically. And, kids are obviously, whether we have our own children, that, brings back memories for, or we had that one bad experience, medically, that, it just creates that, fear and anxiety and, a crying, screaming kid, in the midst of a medical emergency, I think gets everybody's pulse up.
Oh, yeah. I think, a lot of that just is basic biology. Like our brains are just wired to react to a child crying.
Sure.
But, I guess in your experience, what's the best way to overcome those, apprehensions?
Well, I think when we talk about, gaining skills, at least the terminology both we use in the military as well as, in medical education, is gaining knowledge, skills, and you can call it attitude or abilities, depending what school you thought you're in. But anyway, going back to those basics of knowledge, skills, and abilities, I think that will give you that confidence. So, getting that background knowledge, whether it's, just through free open access media like this, reading up on it, if you know what to do, that gives, that certainly can help, right? Mm-hmm. Skills, practicing on cast trainers, simulated equipment, or just getting some hands-on experience in a pediatric emergency room can certainly help. And then, when you think about attitude or abilities, I think it's just confidence and getting those sets and reps in, helps you to gain confidence for that next time around in the real life.
Yeah, absolutely. It's one thing to talk about, different treatments and how they're different and things like that, but, you never get to any treatment without some kind of assessment. So when I do my assessments, I do not have any of the pediatric vital signs memorized. I just have them either written down or I use some kind of reference. And the most common one, I think, is the Broslow tape. What's the good and bad of just using references all the time, I guess?
Well, I think it's essential, especially if you're not seeing kids frequently. whether it's for vital signs or for equipment sizes or for medication doses. I mean, I absolutely use my iPhone here for, looking at medication doses that I'm not using frequently. So, Broslo is certainly good for just giving you general reference of what's appropriate, basic vital signs. So, I think that's okay. If you, I was just doing a quick scan on the App Store here, and there's quite a few reference apps that are out there, that I think are any one of them are probably fine for just giving you a general idea. When it comes to vital signs, having worked with kids a lot, I'm not really checking it for vital signs. I can just kind of look at it and tell that it's abnormal or normal. But I don't think it's necessary to try to, look at a table and memorize it. Having a card, that you print off, whether it's a 3x5 card or a commercial card that you can have in your pocket, or the Broslo tape, I think is certainly reasonable for that. And a couple things on a Broslo, I think are a little out of date are some of the equipment pieces. For instance, the endotracheal tube, they are still going old school, where a cuff tube is not recommended below age 8. That's kind of old school, where we use cuff tubes down in infants even. But for the most part, as a general reference, I think it's fine to use.
Okay. Is there any source in the pediatric world, is there any source that's considered like the gold standard?
Sorry, you cut out there. Could you repeat that question?
In the pediatric world, is there any source that's considered the gold standard?
Well, all of my pediatric residents are carrying a Harriet Lane handbook. That's a textbook put out by Johns Hopkins, and so that's their typical reference. And honestly, for when they're assessing kids, their vital signs are either using that, an app, or they just are printing out a card that they have in their pocket to to refer to. So I wouldn't say there's a gold standard app that's out there. I was just looking, and there's a variety, I think, that are
right.
fine.
I was just thinking, like associations, like American Pediatric Association or somebody like that,
that are going to have reference values.
Yeah.
When you're looking at PALS, that's American Heart Association, reference. The American Academy of Pediatrics has some material, but I'm not sure they actually have a reference card just specifically for vital signs. Certainly they have a lot of clinical practice guidelines and algorithms that are good.
Okay. So on their website they have pediatric specific CPGs?
Yeah, they have CPGs, so say for dealing with bronchiolitis or with hyperbilirubinemia. So there's references I can give for that. Okay.
So assessments, definitely I'm going to absolutely need to use references for that, because at least for the parameters of an assessment anyway. Just because I do not have enough space between my ears to fill with that stuff.
Right.
But I do know the basics, right? So one of the basics are the March algorithm that we have. Now, a lot of the gear that we're carrying is very adult specific when it comes to like massive hemorrhage, say. Is there any considerations, other than just stop the bleed with whatever you're able to do, but is there any other considerations as far as hemorrhage control goes?
So there's actually been good experience with our, combat application tourniquets with children of all sizes that have been used in the military and theater. Just because they're a little kid with a arterial bleed doesn't mean you can't use a tourniquet. So the basic principle is the same. You need to stop the bleeding.
Right.
And that said, you don't necessarily have to apply a tourniquet if you can use your basic maneuvers, right? Whether it's direct pressure, elevation. But don't let that stop you from using a tourniquet just because their arm is smaller or their leg is smaller. So extremity hemorrhage, absolutely go ahead and apply a tourniquet for those severe bleeds.
Okay. that's very basic. Stop the bleeding, right? But airway, now things definitely get a little more dicey because anatomically, children can be a little bit different than adults in where I guess the narrowest point of the airway is anyway. And they have some specific interventions, such as the needle jet. I guess, basic, how about just starting off with just basic differences in airway stuff?
Right. Well, I think backing up first just to assessment, if you're, approaching the situation and, there's blood everywhere, and the kid is, you have this little, infant or 1-year-old that's, screaming, crying, right away, even though that's a scary situation, I'm actually reassured. And I'm reassured because I'm hearing that loud cry, right? So if I'm hearing a loud cry, they got airway check, breathing check, right? And they got some good perfusion to their brain, at least, enough to be angry and crying, right? So right away, you have airway, breathing, circulation, right? So certainly, they could still have a massive hemorrhage you need to control, but, at least airway and breathing are adequate. So you need to be more concerned in your assessment as if, the child who's not responding, right? Not responsive. So, in terms of basic anatomy, obviously, things are smaller, right?
Right.
And when you're thinking about airway resistance, it's not a direct relationship. When you think about going back to physics in terms of Poisson's law, because resistance is a function of the inverse of radius to the 4th power. So, whereas, us adults, we could have a nice large 8 millimeter airway, so our diameter is 4 millimeters. Our radius is 4 millimeters, and so, a little bit of 1 millimeter of edema is not a big deal. But if you have an infant with a 4 millimeter diameter airway, the radius is 2 millimeters, and so, 1 millimeter of edema, you're decreasing the radius by half, and so that resistance increases 16-fold. And that narrowest portion, like you're just mentioning, is subglottic, so it's right, beneath the cords. So that's the area that's, typically swollen when we talk about diseases like croup, or sometimes you get post-extubation stridor after taking a tube out. So the point is it doesn't take much swelling in a small child. Even if it's the same amount of swelling for an adult and a child, it doesn't take much for an infant to cause significant resistance and therefore stridor on presentation. So that's probably the most important difference is that narrowing smallest point that's below the vocal cords. And that's because when you're looking at it from the side, they have this clonal shaped airway. Whereas in us adults, and the same as for older children, adolescents, it's above age, say 10, it's more cylindrical shaped. So the narrowest portion is really just going to be the vocal cords. So if you get a tube through the vocal cords, you're generally fine. Whereas in children, you can get resistance below the vocal cords if your tube is too big. Then some other differences in children. The glottic area is a little bit more cranially oriented and also a little bit more anterior. And so when things are anterior, it can be difficult to visualize. And then most important is when you're, say if you need to intubate, the whole reason you're using a straight blade or a Miller blade is because their epiglottis is floppier. So the cartilage, epiglottis is made as cartilage, right? And cartilage is less formed in infants. If you feel an infant's nose or ears, it's going to be, squishier, right? And so the same applies to their epiglottis. And so you need to get active control of that epiglottis to lift it out of the view of the vocal cords in order to have good visualization if you're going to intubate. So that's the importance of using a straight blade for children, especially under age, say, 2.
Right. Now, I know a lot of, at the schoolhouse I teach, one of the skills I teach anyway is intubation with, using it. And a lot of guys, they like using the Macintosh, for the adults anyway. Now, can you use a Macintosh with a Miller type technique if you've gotten used to using one?
Not really. So the Macintosh or the curved blade, you slide it down the posterior tongue and it goes into vallecula, that little corner, just above the epiglottis, and hits that little ligament to lift up the epiglottis, so to visualize the chords. That said, because it's curved, it's kind of hard to get control of the epiglottis. But with a Miller blade or a straight blade, you can use a Macintosh technique. So you can kind of just slide a straight blade into the vallecula, and if there's, depending on the view and the epiglottis, you might be able to lift the epiglottis without actually, with the tip of the Miller blade in the vallecula. So that's a technique. And then if you can start that way, and then if you cannot get good visualization because of the epiglottis, you just reach down and, lift up the epiglottis, with that straight blade.
Right. On intubation, I found that a lot of people with pediatrics, just going through pediatric surgery rotations, the problem is generally somebody has gone too deep with their blade. Have you found that to be true?
Yeah. Especially with, smaller child with the straight blades. Like generally you put the blade in and, the first hole you're looking at is going to be the esophagus. So, try not to intubate unless you're seeing two holes, right? And go for the one that's anterior, on the anterior side. So that is a frequent issue. We jumped straight to intubation, but we should probably back up,
right?
Because, the most important skill to have in terms of airway and breathing is really just good, bag valve mask technique. And, definitely seen some horror stories of even in the field having reasonable, airway breathing. So good chest rise and having that in the field. However, they went to intubate because, say the child was obtunded, and, went in the esophagus, and therefore you've got zero ventilation and oxygenation going on, right? And the kid comes in obtunded or with significant hypoxic injury. So, certainly important to know your skills, and, the enemy of good is better sometimes, right? So if you have reasonable oxygenation ventilation with what you have, just stick with it, and knowing your skills. And know the airway adjuncts, for the vast majority of the time, if you're not able to get good chest rise with basic BVM, getting your OPA airway, your NPA airway, or even an LMA is so much simpler to do and will buy you plenty of time until you can get somebody with more skills at the bedside.
Right. Do they make eye gels for pediatrics?
They make LMAs go all the way down to infant size. I need I don't know offhand about the eye gel size. I know they go down to a size 3 at least. I was just looking at one. I forget if they go down to 1 to 2 size.
Right.
But they definitely go down. You definitely get LMAs that go all the way down to an infant size.
Mm-hmm. Yeah. As far as, I guess, technique with the getting the seal, are there any kind of tricks of the trade to getting a good seal on an infant? Or a young
with
child?
bag valve mask?
Yeah.
When I'm training residents, oftentimes, they actually have an easier time generally with the infant and child mannequins compared to the adult mannequin. And basically just because of the size of the grip. I mean, especially, I think the most challenging bag valve ventilation are your obese adult, right? Where you may need to go to that two-handed technique. But, I think with an appropriately sized mask on an infant and child, just doing the CE technique, that we all teach, it's not nearly as hard of getting a good seal there compared to dealing with adult, assuming there's not, dysmorphisms, with say, some unique special child. Right.
When it comes to children, advanced airways, you have your intubation, you have Crike, and you have needle jet. And I've kind of heard arguments going both directions. I guess what is your opinion on that?
Well, in terms of, we teach our medics to be very adept at getting, emergent cricothyrotomies, right?
Mm-hmm.
But for kids, if you look at guidelines, and depending on which society you're asking, whether it's ATLS or some others, they generally don't. It's not recommended under age 12 or 10 or 8, depending on what reference you're looking at.
Okay.
That said, there are some smaller pediatric cric devices out there, which are certainly doable for that middle age range. When you get down to the infant size, though, it's going to be extremely difficult to get a tube, into their neck, just because of the size of the neck, the size of the cricothyroid membrane. It just makes it very difficult. And so, in terms of just typical guidelines, if you're looking at ATLS, that it's recommended to do the needle cricothyrotomy. That said, it can be difficult ventilating them, depending what kind of setup you have. So, if you're talking about technique, you're taking, typically you're grabbing your largest needle that you have. So whether it's 12, 13 gauge needle with a syringe, and then just insert it around that cricothyroid membrane area. It might be landmarks are going to be very difficult when you're on a super small kid. Inserting it, aspirating back until you get air, right? Then that you're in the airway, and you insert your catheter. Remember though that those big needles are also long. Those larger ones are like 3 inches long, and so
3.5.
So if you're putting it in, there's definitely a danger of going through and through. So once you get air, you need to stop inserting the sharp part of the needle and slide that catheter in. At that point, there's a couple things you can do. You can take the cap on the 3.0 ET tube, and that can attach directly to the catheter, and then you can just provide BVM that way. It's going to be, there's more resistance, right? Because it's just a catheter, but you'll provide some oxygenation. There are a couple of devices out there, or you can kind of MacGyver one yourself in terms of providing jet ventilation, where you're intermittently occluding, whether it's the oxygen tubing or the airway device, as you're bagging. So that will provide some ventilation, and you can buy, certainly, I'm not sure how much longer in terms of good ventilation there. Essentially another good 45 minutes or so doing that technique. Generally, these are buying time, right? In terms of buying time, so you don't have horrible anoxic injury or brain death. So you can get some oxygenation going while you're obtaining a more definitive airway. It's probably helpful if you just to have a setup available, or you can just put one in a Ziploc bag just in case, right? Because to try to find all the little pieces to do this, while you have a kid that's saturating, 0 is going to be very difficult. So to have a little kit available is probably the best way to go.
Would you say this technique is more about providing oxygen than actual ventilation? And I guess what I mean by that is I'm just breathing through that tiny little catheter. I'm fairly confident I can get enough oxygen in there. I'm not certain that I can get enough CO2 out.
Correct.
Okay.
But, that will at least, as you're in the midst of that emergency, that oxygenation will at least provide oxygenation to the brain, right? So
right.
Your carbon dioxide levels are going to go up, your pH is going to go down.
Mm-hmm.
But that said, that's a better situation than having your O2 levels, in the toilet and killing brain cells. So.
Oh yeah, absolutely. But this is definitely a temporizing measure. I'm not going to use this for hours. This is just a bridge to get me from, almost dead to actual airway.
Right. So it's not a prolonged field care type of maneuver. It's it's temporizing until you can get some sort of advanced airway in. So, and again, it's pretty rare, right? So it's usually the significant obstruction or horrible say facial trauma that, you're going to need to do this type of thing. Because, 99% of cases, simple BVM with your airway adjuncts LMA, you should be fine in terms of providing good oxygenation and ventilation.
You mentioned obstruction, and that had come up on social media as a situation in pediatrics where the patient, will make up an infant-sized patient, had swallowed an object. It's lodged into the trachea, and they're not able to provide ventilation. So the debate was, do you do a needled crike, or do you try with the ET tube to push, since you can't get the object up and out, do you push it down and in? I remember as a student years ago them telling us that. I don't know if they're still telling people that or not. Just to use the ET tube and push it past the carina so you can ventilate one lung. I guess, what are your thoughts on that?
Well, I guess my first concern would be is if, the size, depending on the size of the object, what if you can't push it past the carina, right? You're done. You're absolutely stuck then, because, so it's a huge gamble, I guess, unless you know that that object could go down one lung and you can provide single lung ventilation, which would be fine. But if you can't, then if it's sitting at that main stem, even doing, emergent crike, maneuver, you're right. You're above the problem. Right. And so, I would much rather, if I'm in that supraglottic, significant obstruction, would be to, do the needle crike, and then, see if you can take some McGill's or, try to at least temporize till you get, some, advanced, ENT surgeon there to pull that out.
Yeah, that's definitely. But I remember as a student them teaching us that. I'm not sure if that's still a thing anymore. But anyway.
Yeah, I haven't heard it of being a thing. So I certainly wouldn't say, that would be your primary goal would be to just shove it down there, because that just scares me thinking about it.
Right. Yeah, absolutely. Again, I'm sure it probably could have been something that an instructor made up. So on from airway. Okay, so securing the airway, we have respirations. So, for an adult, we have ARDSNet. As far as how many mLs per kilogram we can use for tidal volume, is there any kind of parameters for the pediatric as well?
Well, the good news is that, since ARDSNet uses per kilo dosing, so to speak, of tidal volumes, is that, you can actually use the same guidelines in children. So, in all pediatric critical care, we typically follow the same adult guidelines, that's been studying kids. So, whether it's, so with significant lung disease, using 6 to 8 per kilo, 5 to 7 per kilo, in that range, using permissive hypercapnia, increasing PEEP, as necessary is all the same maneuvers I would do in a 3-year-old and I would do in a 21-year-old.
Okay.
So, I think some people get scared of increasing PEEP in a child because they think they might pop or whatever.
Right.
The risk of pneumothorax is the same in an adult, in a kid, assuming that you're, using appropriate tidal volume per kilo. So,
right.
So as long as you're dosing it right, it's appropriate, right? If you're going to use the same tidal volume in a child that you would in adults, so it becomes suddenly 20 per kilo, and then you have the risk of barotrauma and pneumothorax. But just go by weight and dose it per kilo, and actually ARDSNet strategies can be applied in children.
All right, very good. Now, the other side of that coin. In your sphere of influence, I'm sure you're using pediatric BVMs in your pediatric ICU, but I'm only carrying one and it's an adult. Are there any kind of tips that you can give for somebody? I have an adult BVM. I need to use it on a pediatric safely.
Well, you adapt and overcome, and I guess, and work with what you have.
Right.
You're doing it by, can you get a good, if you only have an adult mask, are you able to get a good seal, with that or not? I think you just have to, do with what you can. It might take, maybe over the whole face, and turning it around, you can just, troubleshoot that and see. What's most important is that you can get chest rise, right? So that's really what you're going by. You don't need to squeeze the entire bag because it's a much, larger bag that you have with an adult, assuming that you have an infant there. So just get chest rise and then you can stop squeezing. There's going to be a lot more nuances when we don't need to go into the details of mechanical ventilation, but for a small child, if you only have an adult circuit, you could potentially run into problems there, just because of the dead space in the circuit tubing, especially under 10 kilos or so. And so, in an infant and, without, an infant circuit, your best bet may just be providing, manual ventilation, through the ET tube, looking at chest rise and hopefully just going by, with your end tidal device, assuming you have an end tidal device, that's just as good as a ventilator in many.
Right. It's definitely more respects, adaptable. Right? They're at least more adaptable than the ones that we have.
Right.
But
that's always our fallback, even in the ICU. With our advanced ventilators, if things aren't just working right, we disconnect them and we hook them up to a bag and we just bag them, with manually and go by that. And so, in a prolonged field care setting, that may be what you're doing.
Mm-hmm. So going off from after respirations, we have our circulation. That's where we're starting up our resuscitations. Fluid challenges. I'm very confident they're different between pediatric and an adult as far as how much volume you can give somebody, since I imagine a child, you could probably completely fill their tank with one unit.
Right. Well, if you look at if the size of your bag of blood or saline is the same size as the child, you probably shouldn't give the whole thing, right?
Right.
So, in terms of dosing a bolus of whatever that fluid is, generally we're talking, the rule of thumb is around 15-20 per kilo, cc's per kilo. So that's what we consider a volume bolus. So for a child coming in who's dehydrated, and you need to give fluid, generally you give a bolus of 20 per kilo of your resuscitation fluid and then reassess and repeat.
Okay. And then you just continue that until you've achieved your whatever blood pressure goals or urine output?
Correct. So just those same indicators that you have in adults, looking at heart rate, that said, heart rates are going to be a little different in your smaller child, but, does their heart rate start coming down? They're making urine. So those will be your indicators that you've resuscitated in a setting of dehydration. In terms of hemorrhage, then you're using blood, and, we have the same concerns of using crystalloids in children just that we do in adults. So, I'm hesitant to give crystalloid in a setting of a bleeding child, have that same hesitation as I would in an adult. So you want to give blood. That said, you're dosing it per kilo, in that 15 to 20 per kilo. And you also want to listen to the lungs, right, and listen to the heart. So you don't want to be overdoing it and causing fluid overload, just as you don't want to cause fluid overload in an adult. Do you have crackles? Is the liver starting to come down? Okay. when you do your assessment.
Okay. But urine output goals, are you going by cc's per kilogram, or is there Like for adults, it's 30 to 50 cc's.
Right. So, again, we have to do math, unfortunately, in children, right? So it's around 1 per kilo per hour is our general goal. So anywhere, half to 1 cc per kilo, I'd be happy about.
Okay. Mentioning dosages, with hemorrhage, TXA. I've only been ever told 1 gram, or 2 grams. So I don't know that there is other doses. Are there other doses?
Well, know that, TXA is not, has not been studied as well in kids. So, when we do this stuff, we are extrapolating from adult data, and obviously we have great adult data with the CRASH 2 study out there, and even with the CRASH 3 with head injury and other stuff. So be cognizant of that. And there's a couple limited studies on retrospective data suggesting that it may be a benefit. So that said, it's kind of dealer's choice. In terms of dosing, there's some suggested dosing. For the most part, TXA is a relatively safe drug. Different doses have been used for surgeries, for decreasing bleeding in surgery or decreasing transfusion needs in pediatric surgery. So those have been studied. The European guidelines suggest around 15 milligram per kilo bolus, or loading dose rather, for TXA for children. So, I think that's probably the most common one that you see. You might, if you're looking it up, you might see some massive doses of TXA, even going up to 50 per 100 megs per kg. But that said, those are in a setting of like bypass, and you have, a whole extra circuit there. So, I wouldn't give that much, but the Europeans are suggesting around 15 milligrams per kilo. So if you're going to give it, that would be what I would use.
Okay. Are they finding
probably the same caveats? Are
they finding success with it?
The data is really not out there.
Okay.
Unfortunately, so there's no prospective trial yet.
Right.
Studying TXA versus nothing. It's definitely starting to be used more and more. So I think more data will come in. Since people are using the adult studies to inform our practice in children. But that data again is going to be, you're going to have to do some statistical maneuvering to see if it's actually of benefit until you do a controlled trial, such as the CRASH trial. So there's no similar study in children. So, there's some suggested benefit on, 2 small studies, saying it may be a benefit using the same, 1 to 3 hours, less than 3 hours from injury. But again, unfortunately, this is a problem we run into often in children, is that all the studies are done in adults, and, we're reading the notes in the studies, the literature from adults, and trying to do our best to apply it to children, using common sense. Just checking my notes here. We didn't mention calcium. That's probably one other,
right.
thing to note. Calcium is, essential in adults and essential in kids, even more so in your infants, because in infants, their heart is very sensitive to hypocalcemia.
Oh, okay.
So it's almost an inotrope in children, because the heart muscle needs calcium in order for the actin myosin to work.
Right.
And especially the immature heart. So, if you're transfusing, you need to be giving calcium, dosed appropriately, for a kid. And so, again, don't forget that.
Would you use, I can look up the dose unless you have it right now, but, would you use it in the same, interval? So like we give 1 gram up front, and then somewhere between 2 and 4 units, we'll give another gram and continue until the day is over. But, would you continue with an interval like that, or? Yeah,
especially if you can't check it. I think if you can't check it, you do need to just make a note to give it with after on a similar interval that you're doing in adults. The dose, for kids, you can use either calcium chloride or calcium gluconate. Calcium chloride is like 5 to 10 milligrams per kilo. Calcium gluconate is 50 to 100 milligrams per kilo. But yes, I would give it, with that first unit, and then empirically, thereafter, as you're just as you would in an adult.
Okay.
It's probably best to keep it simple and do this at the same interval that you're doing in adult, dosed appropriately.
Right. So maybe if you're bolusing, was it 15 to 20 cc's per kilogram, maybe after 2 to 4 boluses, since you're not going to use a whole units, give another, 50 to 100 milligrams.
To the calcium gluconate. Right. Yeah. I mean, I think it's probably safe to err on the, slightly higher side. So, every couple units or doses you're giving of blood or plasma, to give that empiric dose of calcium.
Right. Since they're so sensitive, their heart rate is how they're increasing their cardiac output. Would you say, if you're noticing that you're giving fluids and their heart rate is not coming down, that's probably a good time to give calcium because they're not really responding to the fluid?
Potentially.
Okay.
It's also inotropy too, so they may not be squeezing as well. So you may just be hypotension that you're seeing.
Okay.
So, if you're giving a bunch of blood and you're hypotensive, that could be purely because of low calcium.
Mm-hmm.
One final circulation thing we kind of skipped over right in the beginning is access. So,
right.
Getting IVs in small children is difficult. So, there's definitely some IV experts that are out there and can get it no problem. But, if you're not seeing kids too much and you have, this emergent scenario arriving, don't be afraid to use IO. And, if it's an emergency, you probably don't even want to waste time if you know you're not great stick on a 1-year-old or a 6-month-old. Just go right to the IO.
Right.
I think most of us are familiar with the Aero Easy IO device, the drill.
Mm-hmm.
And, there's past trainers out there to practice that, which are, I think, good to use. They have the smaller pink needle for infants. You can do the similar locations that you do in adults. So that said, with that device, always typically first shot I'm going proximal tibia just because the landmarks are easiest. But you can go proximal humerus or iliac crest with that device as well. There is a app, I think a useful app that is put out by the maker of the Easy IO device that you can download to Android or iPhone that has some good references, some good videos of finding anatomic locations for doing that. So it's probably something good to review, if you haven't done that procedure.
Right. Yeah, absolutely. I mean, I've at least attempted on some very small children, and it humbles you really quick. When you're the one Johnny on the spot on an adult, and then you're given a child, and like you fail, it definitely humbles you really quickly. So, I think having that the ability to give IO is probably a really smart option. Now, I guess any real differences with a distributive type shock?
When we get into sepsis, kids can present a little differently. When we just think about circulation, so children, small children, infants especially, increase their cardiac output by heart rate. They cannot increase their stroke volume. And they're also very good at compensating for shock. So they have a strong catecholamine release. They can, which causes them to, constrict all their blood vessels, and they can maintain their blood pressure very well. On and often with very high heart rates. So it's not uncommon to see a infant coming in with a heart rate of 220, and it's not SVT, it's just catecholamines.
Right.
And that goes back to assessment, actually. If you see a very high heart rate in an infant, is that heart rate when it's in that, say, 200 range, low 200s, if they're screaming and crying at you, it could just be because they're angry. And so when they calm down, does that heart rate come down? It's like that would be more reassuring. If they're coming in kind of obtunded or, not crying and their heart rate is that high, then you need to be thinking, all right, this kid's in compensated shock. I need to do some sort of resuscitation. If their heart rate is up in like the 290s, then all right, this is likely SVT. I need to go down that algorithm. But just because you see that number above 200 does not mean it's SVT in an infant. So I think that's one important point. So again, the heart rate is the main way small children increase their cardiac output. So when we're thinking about shock, you don't necessarily need to, and because they've increased their all these catecholamines, they've clamped down on the blood vessels. If they're very, say, cold on exam, you don't need to give them more vasopressor. So whereas I think norepinephrine is your typical go-to drug in a adult with distributed shock. If the child feels very cold on exam, you may choose something like epinephrine. That said, you can have, in a child growing up, you could certainly have them, you have to do your exam, right? So if they have signs of distributive shock, if they're warm, vasodilated, you need to consider, something like norepi.
I think the last thing is like head injuries. Oh, there you go. Head injuries, hypothermia for March. Head injuries. How does the neuro exam change with a pediatric?
Yeah, well, I remember it being told to me in training when I was way back when was, that pediatrics in this age group can be a lot like veterinary medicine, right? Because, you don't, when you're not talking to you can't ask them how they're feeling and, how's it hurt on a scale of 1 to 10. So, it does take some experience. And, this is where, the parents can come, very much into play, right? So, the mom, the dad, they know the child best, right? So you can ask them, is this what the child normally looks like? Or, tell us, what's going on, especially if it's a child who has some underlying neurologic, dysfunction. TBI is certainly a big, issue in trauma in children. That said, the main principle, for head injuries is the same as an adult and kids, and that is what's most important is preventing hypoxia and preventing hypotension. Because remember, the whole point in dealing with TBI is that you provide oxygenated blood to the brain. So, if a child is coming in with a head injury, while yes, it's a scary issue, again, it comes back down to your ABCs, right? So, first, the first two things I'm going to check is, your airway, breathing, circulation. Are they going to, what's their saturation? Are they well saturated? Do I need to give oxygen? Do I need to do more advanced airway maneuvers? And then what's their blood pressure? Do I need to provide some resuscitation? Do they need a pressor? Do they need blood, to provide, that good perfusion to the brain? And, you could consider, TXA, but that's not necessarily part of the main guidelines. So, sticking to the basics, preventing hypoxia, preventing hypotension is the two most important things in children, just as in adults. And that said, your differences in airway and circulation that we just discussed will come into play, but, don't get away from the basics.
Right. Is there any other kind of tips along these lines that we've been talking about that you'd like to add? Maybe just a couple small notes, as we're thinking about the brain and seizures, that children are more at risk of hypoglycemia, just because their glucose stores, especially in an infant. If you have in the field the ability to check glucose, especially if they're obtunded or if they have the seizure, check glucose. And if you don't have the ability to do
an Accu-Chek or point of care glucose. Give glucose empirically. I think the harm of giving glucose is pretty minimal, right? But severe hypoglycemia could cause significant problems. So checking a glucose, I think, should be part of your basic assessment. And then in terms of thinking of other disability type things, children are also at higher risk of hypothermia, just because of the their ability to maintain homeostasis and their fat stores and their body surface area. Mm-hmm. So your small infants, ideally, make sure that they're warm or that you cover them quick after you do your assessment, because the same issues, if we're thinking about trauma, apply. That hypothermia is bad in children, and it's bad in adults in the setting of trauma, right? So,
well, plus they also have a smaller blood volume to actually lose. So even a little bit can be catastrophic.
Right. And it can be internal, right? So you may not see it. So.
Right. Does your FAST exam really change that much?
No, I think I think it's great to get some practice on a smaller child. But in a PFC setting, I think ultrasound is of great use. And it's not used enough, in a pre-hospital setting. It gives you great information in terms of, looking for, free fluid in the belly. It gives you great information of looking at, potential for pneumothorax or hemothorax. So I think there's great utility in ultrasound in children. And I think a lot of people are recognizing that now and starting to add those skills.
Right. Yeah, definitely in the training in training environments I've been in, you can definitely see the comfort with doing a FAST exam or just using an ultrasound in general is definitely coming up. At least with the basic exams. So that's a very good thing, I think. No, outstanding. To be honest, I can't really think of anything else. Do you have any other tidbits that you'd like to give?
I think for our basic March algorithm, I think we hit the highlight.
For today's podcast, be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.